after we're done with the exposure, you all know about loop tape exposures, right? If you don't, you can see me afterwards because I know we're running out of time. Then we have to tweak it to include humor into it. And humor is so necessary in exposures because once you're able to see the humor in the situation, then it's almost like the fear is no longer as powerful as it originally is. And then after we do it with humor, we then tweak it again, the same loop tape, we tweak it again to include a realistic situation. So which is, I'm going to the dentist or I'm getting a shot, it's gonna hurt a little bit, however, the needle's not gonna break, I'm not gonna be bleeding out my arm, so it's gonna be based on reality. And then when the patient is ready, we develop a hierarchy from the lowest feared the lowest feared trigger to the highest feared trigger, and we start taking the patient through these avoidances, external avoidances. So for example, from 0 to 10, what number would you be at if we visited a dentist's office without actually going in? From 0 to 10, where would you be if we talked to a dentist without making an appointment? From 0 to 10, what would it be if we went and actually saw people getting dental work done? So we're gradually exposing the patient to external cues. And then there's cognitive restructuring. Again, it's to change the beliefs, the attitudes, the faulty schemas, so that they are correct about the situation and they're not having these false assumptions of the worst possible consequences. And a couple of strategies: psychoeducation gives them the accurate information, reframing faulty assumptions through the automatic thought record, appealing to logic, such as Socratic questioning, and doing experiments, such as, let's go do a survey and see how many people have believed that this will happen when they go to the dentist. So we're using these tactics to change their beliefs. However, that is not going to be as effective as behavioral exposures because behavioral exposures give you that corrective feedback. And then some treatment considerations. I think the most important thing here is that you continually assess. The reason being is that fears are not static. They're not going to just be this and then you treat this and then it's gone and the person is cured. Fears evolve over time and then they change and they manifest in different ways. And your job is to be able to detect those changes as treatment progresses so that you're continually targeting whatever manifestations come up with the fears. Okay? Questions? Yes?
Are you saying that new fears will come up over the course of treatment?
Well, not necessarily complete new fears, although that could happen as well. However, the person, maybe the person wasn't afraid of doctors, was just afraid of dentists. As we treat the dentist phobia, the person may now realize that, hey, I'm not just afraid of dentists, I'm also afraid of doctors. Although the person may not have realized it before because they were so consumed with their dental fear, as we start treating fears, some of these other fears would come up. And our goal is to be able to tackle those fears. Or, for example, a person with dental fear may avoid going to the dentist. However, after we treat them going to the dentist and they're able to go to the dentist, they're still not able to brush their teeth on their own. So we start to tackle.
Fears are dominate. I understand.
Yes.
Fears are dominated, and we take care of those. That's what fears like work.
Yes.
Thank you. Thank you.
Yes. Okay. Questions? Other questions? Yes.
How many sessions do you need on average to treat this dental phobia?
It depends. It depends on whether there are other comorbid conditions such as panic attacks, whether, how many different fears they have. That all depends on the assessments. And depending on that, it could be as few as 6, 7 sessions to as many as 25, 30, 40 sessions. Yeah, it really depends. And of course, the longer that they've avoided, the more the fear has been reinforced and the more difficult it will be to get them to expose. And also patients with a higher level of avoidance, they're going to be more difficult to convince to do exposures. Okay? Yes?
What is your, will have, or the kids will have them, the pediatrician will prescribe, steroids or Ativan for the night before a procedure so that they're well rested when they come in? Can prescribe or not prescribe that kind of, our thought is if they're well rested, then they're better able to cope and
That is true.
apply.
That is true. Your level of sleep will determine your mood level, your susceptibility to stress and anxiety. That is very true. However, then the question is balancing, is it absolutely necessary to prescribe a 5-year-old Valium? What are you doing to that 5-year-old's body when you're prescribing him Valium or Xanax? I come from a school where drugs are really, unless the child is so debilitated that the child cannot make it without the drug, I'm not a proponent of medicating children at all. I mean, of course, there are children who aren't that severe, and they're not able to even get out of bed to get to the dentist's office or get to your office to do exposures.
There's a new breed of dentists that are going back to school for a year of anesthesia and do nightly sedation to treat dental problems themselves.
Yes.
Do you have anything on that? You're a dental, you're a dentist?
I am a dentist. I have a course in nitrous oxygen sedation, it's called that.
Nightly sedation.
Yeah, I think it's like a Valium or so.
Yeah.
It covers the anxiety.
Valium demo.
Yeah, so I think the only thing when it's useful is to treat patients with a severe gag reflex, which is not based on the trauma. When they have a traumatic experience like abuse, then you can, for instance, do the trauma. But when you have a gag reflex and you don't know what is, and nothing helps when you try exposure, as you said, and nothing
Right.
helps. Well, that's an option to use, in my opinion. But
We actually did a focus group with a bunch of dentists. One of my friends is the owner of 1-800-DENTIST. And what we were trying to do was implement a program for dentists so that they can get the training that they need to work with patients who do a lot of cancellations. And I would say that the majority of the responses that we got, first of all, not a lot of dentists showed up at this focus group. And the reason why they didn't show up is because they said, oh, we've got these other type of sedating methods that is so much easier. On top of that, insurance will reimburse, and they don't need to spend their own time and money getting training to do this same procedure. So that is the mentality out there, is that most dentists are going to prefer sedating their patients because, again, it's reimbursed by insurance, and it's just less time and less effort on their part. Now, for the patient's part, of course, that doesn't help you learn that there isn't a catastrophic consequence to going to the dentist, because each time you go and get sedated, what you're doing is you're reinforcing that going to the dentist requires sedation because it can be traumatic. So the question is which time?
It's still anesthesia, you don't want to repeatedly expose, especially for, I'm just thinking kids, we can't do it.
Right.
They'll do it once and that's it.
So again, it's, which side are you looking at it from? And I can understand the other side, but I'm advocating for the patients. Yes.
I think there is a place for, I'm talking like Xanax for adults, because we severe panic attack patients. This is in a general practice with patients with general dental anxiety, and, you know, most of them, we give the Xanax to them once, and once they get back in the ballgame, they use the Xanax once or twice, and
Sure.
they never use it again.
Sure.
So it's not like it's a habitual,
Right.
you know, so I think there is a place for the Xanax, you know, but I don't think it should be all the time. either,
Oh,
like
of
you
course.
said.
I mean,
I don't think it should be every time you go to the.
right, I'm not a critic of Xanax or, Valium, and, if I'm ruminating in my head, I wouldn't mind taking one myself. What I'm saying is the person who's chronically on it and who can't function without
Right.
it, And I have some people who enjoy going to the dentist so that they can get a prescription of Valium or Xanax, so.
So I don't know how I feel about the IV sedation, because then how do they, I mean, with the Xanax, they're still conscious and they can still learn to.
Yeah, I'm not sure about
That
that.
sedation is people that they'll go like 20 or 30 years, and they'll do like 7 root canals in 6 hours.
Right.
and
Right.
$30,000.
Right.
So that's kind of
Only
similar,
procedure.
that's similar like having your wisdom tooth taken out and
Right.
you need some sort of sedation for
Right,
that.
right.
Yes.
Yeah, I think the only, when you have complete anesthesia, I think the only category of patients is the patients with, for instance, a lot of traumas,
Mhm.
abuse, schizophrenia, and they have all the teeth, they neglected their teeth for 20, 30 years, so everything should be extracted. And I think that's the
Right.
only reason, and you can help them in one
But
time.
that's just
I
like
think
going
that's
in for
the only-
surgery.
Yeah,
Right.
yeah.
Well, thank you guys.
Thank you.
Enjoy the rest of your conference here.
It was very good.
Thank you.